Hi there, my highly valued, treasured and esteemed viewers and listeners. Welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we remain your premier source of crucial tips for very, very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very, very handy in your line of duty. So I welcome you all to part 112 of our Pharmacotherapy MCQ series, which majors in infectious diseases. Welcome. Our first question reads, Mr. KTM, a 56-year-old male patient, presents to your accident and emergency department with a chief complaint of purulent green to yellow nasal discharge, some facial pain to the maxillary sinuses. He is concerned about MRSA and insists you initiate him on something for it. So my question to you is, which of the therapeutic options listed below would you recommend for Mr. KTM, who happens to be a medic? Would you settle for cotrimoxazole, moxifloxacin, clindamycin, or linezolid? I'll give you 10 seconds to choose the correct therapeutic agent. I would choose to treat this gentleman with moxifloxacin. I would like to begin by saying that the IDSA acute bacterial sinusitis guidelines state that routine coverage for MRSA is not recommended, regardless of what the patient wants or thinks he needs. Now, the only antibiotic that doesn't have MRSA coverage and would also treat acute bacterial sinusitis in the above list is moxifloxacin. Remember, clindamycin is not recommended in the guidelines outside of an alternative for children with penicillin allergy, and in such circumstances it's used in combination with cephalosporin. Let's move to the next question, please. And the next question reads, what additional mechanism of action does linezolid have beyond its activity as an antibacterial agent, which can significantly increase the risk of drug-drug interactions, especially with sympathomimetic medications such as tricyclic antidepressants, SSRIs, and tramadol used in pain management? Is it A, linezolid can inhibit renal tubular secretion of these medications for renal elimination, or is it B, linezolid can inhibit the metabolism of the enzyme monoamine oxidase in the brain, or is it true that linezolid can significantly inhibit the cytochrome P450 enzyme system, or is it D, linezolid can also increase the release of norepinephrine and serotonin from the nerve terminal? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Linezolid is a MAO inhibitor. I would just like to start by saying that linezolid is well known to result in non-selective monoamine oxidase inhibition, and this can impair or inhibit the mechanism of sympathomimetic medications. Now, another drug in the same class, tedizolide, marketed as Civextro, is also a monoamine oxidase inhibitor, and it can also cause similar clinically relevant drug-drug interactions. Now, the effect of these medications are increased and can put some patients at a risk of what we call the serotonin syndrome. And they can also lead to cardiovascular side effects when they inhibit MAO in SSRIs, in TCAs, and similar medications. Let's move to the next question, please. And it reads, your infectious diseases consultant has decided to initiate patient ZLW, a middle-aged HIV seropositive patient, on empiric therapy for Toxoplasma gondii encephalitis. This patient is allergic to cotrimoxazole and the allergy was severe. So my question to you is, which of the regimens listed below would be the most appropriate for patient LZW? Would you settle for sulfadiazine and leucovorin? Would you settle for lipid complex amphotericin B and clindamycin? Or would you settle for clindamycin and pyrimethamine? Or would you treat him with a sulfadiazine and pyrimethamine? I'll give you 10 seconds to choose the correct answer. I would treat ZLW with clindamycin and pyrimethamine. Remember, Toxoplasma gondii is an obligate intracellular parasitic alveolate and not a fungus. I'd like to start by reminding you of that. Now, similar to Cryptococcus, Toxoplasma gondii is a potential pathogen for CNS infection in the immunocompromised population, such as this patient. And the first-line treatment is pyrimethamine plus sulfadiazine plus leucovorin. Now, sulfadiazine is often substituted for clindamycin, especially when a patient has sulfur allergy. Now, one of the primary routes of transmission of Toxoplasma gondii is cat feces, just to remind you. Now, T. gondii encephalitis is identified by ring-enhancing lesions, which can be seen on an MRI. There can also be space-occupying lesions, which can be seen on a CT scan. So, those diagnostic tools can be very useful in managing such patients. Now, an alternative diagnostic strategy that spares radiation is a serology for anti-Toxoplasma IgG antibodies. We'd just like to add that leucovorin must never be administered to such patients intrathecally. If you choose to use it via the correct route and avoid the intrathecal route. Let's move to the next question, please. And it reads, as the clinical pharmacy specialist in the infectious diseases team at your hospital, you are reviewing the formulation similarities and differences between itraconazole solution and capsules. With regard to oral bioavailability, which of the statements listed below is correct? Is it true that both formulations should be taken on an empty stomach? Or is it true that both formulations should be taken with food? Or is it true that itraconazole capsules should be taken with food, while the oral formulation via solution form should be taken on an empty stomach? Or is it true that itraconazole capsules should be taken on an empty stomach, while the oral solution should be taken with food? I'll give you 10 seconds to choose the correct answer. So C would be the correct answer in my opinion. Itraconazole capsules should be taken with food, and the oral solution should be taken on an empty stomach. The oral bioavailability of itraconazole capsules is improved when it's taken with meals. That is the rationale behind it. And I would just like to add that absorption is reduced on an empty stomach due to decreased gastric acidity. Remember, when food lands there, it triggers secretion of hydrochloric acid or the gastric juice. Now, the bioavailability of the capsule formulation is reduced with gastric acid suppressors such as the proton pump inhibitors, the H2 receptor blockers, and even antacids can affect it to a small extent. Now, itraconazole solution should be taken on an empty stomach to improve its bioavailability. And I would just like to remind you that the bioavailability of the oral solution is only 55% when it's taken with food. It's grossly reduced indeed. Let's move to the next question, please. And it reads, which of the statements below is true with regard to the use of nitrofurantoin in the management of a female patient with a urinary tract infection, a UTI? Is it true that it can increase uric acid levels and exacerbate a case of gout? Or is it true that it can cause hemolysis in patients with G6PD deficiency? Or is it true that its efficacy is decreased when the creatinine clearance falls below 30 ml per minute? Or is it true that it's commonly used to treat pyelonephritis? I'll give you 10 seconds to choose the correct answer. Both answers B and C are correct. It can cause hemolysis in patients with G6PD deficiency, and its efficacy is decreased when the creatinine clearance falls below 30 ml per minute. Now, nitrofurantoin is commonly used in the treatment of cystitis, that is infection localized to the bladder, which is considered uncomplicated, but not for pyelonephritis, which is considered a complicated UTI and was sometimes referred to as an upper UTI due to its effects on the renal parenchyma. Now, nitrofurantoin's efficacy is dependent on getting into the urine. Now, when the creatinine clearance falls below the 30 ml per minute mark, it is compromised. Its penetration to the urine is compromised, and it is also known to cause hemolysis in patients with G6PD deficiency. So don't gamble and use it in such patients. And just as a by the way, I would like to inform you that the monohydrate or the microcrystal formulation of nitrofurantoin is called macrobid, and it's dosed twice daily, while the regular macrocrystals, if I remember well, the non-monohydrate formulation is known as macrodantin, and it's dosed QID 4 times daily. So remember the difference between the macrobid and the macrodantin. One is BD, the latter is QID. And the duration of therapy is usually 5 days in females and 7 days in males when you are treating cystitis, uncomplicated UTIs. Just remember that for your information. Let's move to the next question, please. And the next question reads, which of the results below would you use to confirm the diagnosis of HIV? Is it A, HIV-1 or HIV test is positive? Or is it B, HIV antigen or antibody positive, and then HIV-1 or HIV-2 are positive? Or is it C, HIV antigen or antibody test is positive? Or is it D, HIV antigen or antibody positive and HIV-1 or HIV-2 are negative? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Now, when confirming an HIV diagnosis, the first step is an HIV antigen test. Now, if it's positive, it should be followed by a second HIV-1 or HIV-2 differentiation test to differentiate between the two. Now, a negative or indeterminate HIV-1 or HIV-2 differentiation test should lead to a third nucleic acid test to either detect early HIV infection, which is when there is a positive results, or a false positive HIV antigen initial test when there is a negative result. According to the CDC, the combination of a positive HIV antigen or antibody assay and a positive HIV or HIV-1 or HIV-2, differentiation assay are necessary to confirm the diagnosis of HIV infection. You don't want to treat a false positive case. Let's move to the next slide, please. And it reads, BJB, a middle-aged American patient from Oklahoma, is admitted to your hospital while on holiday in your country with a chief complaint of severe back pain. He is being evaluated for NVO, native vertebral osteomyelitis. He has a past medical history of anxiety and depression, and currently his blood pressure is 146 systolic, 86 diastolic, with a pulse of 88. The neurologist confirms Mr. BJB's neurological state is stable. So my question to you is, would it be appropriate to initiate antimicrobial therapy in Mr. BJB's case? Would it be A, within 24 hours of obtaining microbiological cultures, or would it be B, immediately, even before microbiologic cultures, or would it be C, immediately after the microbiologic cultures, or is it D, once a microbiologic diagnosis is established? I'll give you 10 seconds to choose the correct answer. I would choose to initiate therapy with antibiotics once a microbiologic diagnosis is established. Now, according to the IDSA NVO guidelines, antimicrobial therapy should be withheld until a microbiologic diagnosis is established for patients with normal and stable neurologic examination and those who have stable hemodynamics. Antimicrobial therapy should be initiated in conjunction with obtaining microbiologic specimens in patients with hemodynamic instability, or those who have sepsis, or those in septic shock, or those who are progressive or have severe neurologic symptoms. I'd just like to add that prior exposure to antibiotic or antimicrobial therapy has been associated with a decrease in the risk of microbiologic yield of what we call the image-guided biopsy in patients with NVO. Therefore, the IDSA NVO guidelines, or the panel that drafted that guideline, believe that holding the antibiotic is feasible for 1 to 2 weeks, and they consider that reasonable so that you treat in a targeted fashion. Now, if a patient is stable, withholding antibiotics should be considered until definitive diagnosis can be obtained of the causative pathogen. We don't want to shoot with a very big gun when there might be no bacterial infection. Let's move to the next question, please. And it reads, which of the electrolytes listed below are decreased in the course of therapy using foscarnet, which puts patients at an increased risk of seizures? Is it chloride, calcium, sodium, or iron? I'll give you 10 seconds to choose the correct answer. Calcium it is. I would like to start by saying that calcium and magnesium levels decrease with the use of foscarnet, marketed as Foscavir, because of their binding to the drug itself. They chelate Foscavir. Now, structurally, foscarnet is negatively charged and can thus bind to cations, and in particular, polyvalent cations such as calcium and magnesium. And severe hypocalcemia can lead to seizures. So that is the rationale. Let's move to the next question, please. And it reads that, according to the CDC, how often should individuals on PrEP follow up with their physician for HIV testing and assessment? Should it be annually? Should it be done every 6 months? Should it be done every 3 months? Or should it be done on a monthly basis? I'll give you 10 seconds to choose the correct answer. It should be done every 3 months. Now, the CDC recommends those on PrEP receive follow-up visits at least every 3 months to be tested for HIV, to undergo review for medication adherence, to receive behavioral risk reduction support, and to receive side effects or STI symptom assessment. Now, renal function needs to be assessed due to the tenofovir component of the PrEP and the potential risks of kidney damage. I would just like to add that current FDA-approved PrEP regimens are either TDF co-formulated with emtricitabine known as Truvada, or TAF co-formulated with the emtricitabine known as Descovy, DESCOVY. Let's move to the next question, please. And it reads, which of the enzymes listed below are inhibited by fluconazole, thereby increasing the risk of drug-drug interactions for their substrates? Is it CYP2D6, 3F4, 2C9, or 1A2? I'll give you 10 seconds to choose the correct enzymes. Fluconazole inhibits both CYP3F4 and 2C9. In addition, it also inhibits CYP2C19, which doesn't appear on that list. Now, the degree of inhibition of CYP3F4 by fluconazole may be less than in other azole antifungals, and it's dose related as quoted in literature. Now, due to the interaction with CYP2C9, caution should be taken when administered to patients on stable warfarin doses, since the S isomer of warfarin is known to be a substrate of 2C9. Be very, very careful. Now, any inhibition of the S isomer of warfarin can increase the INR and even the risk of bleeding. Let's move to the next question, please. And the next question reads, Mr. BHO, a 77-year-old male patient, is admitted to your hospital with osteomyelitis of the left foot due to MRSA. The infectious diseases consultant initiates Mr. BHO on vancomycin infused over an hour. After the surgical operation is done, the orthopedic surgeon reports that there is residual infected soft tissue but not bone. So my question to you is, for how long would Mr. BHO's case be treated? Would it be for 6 weeks, 10 weeks, 3 weeks, or 15 weeks using the vancomycin? I'll give you 10 seconds to choose the correct answer. Three weeks would be the most appropriate or ideal duration of therapy for residual infections of soft tissue but not bone, according to the IDSA DM foot guidelines. I will refer you to those guidelines. Let's move to the next question, please. And the next question reads, Mr. KLM, a middle-aged male patient, is hospitalized at your institution's medical ward with febrile neutropenia following the administration of bendamustine. The infectious diseases consultant empirically initiates this gentleman on cefepime at a dose of 2 grams infused IV thrice daily. 24 hours after his admission, Mr. KLM has 2 positive blood culture sets for gram-positive cocci in clusters. So my question to you is, which of the antibiotic regimen modifications listed below would be appropriate in Mr. KLM's case now? Would you switch from cefepime to meropenem, or would you continue cefepime until culture unsusceptibility results return, or would you add vancomycin to cefepime, or would you consider adding clindamycin to cefepime? I'll give you 10 seconds to choose the correct answer. I would opt to add vancomycin to cefepime. I would like to start by saying that when cultures return for a potential organism that may be resistant to your empiric therapy, a change should be made. In this case, the most probable organism will be Staphylococcus, so the addition of vancomycin is prudent. The vast majority of coagulase negative Staphylococcus species are beta-lactam resistant, and depending on your antibiogram, susceptibilities to Staphylococcus aureus may fluctuate anywhere between 40 and 60% resistant to oxacillin. Now, vancomycin will possess the greatest susceptibilities against Staph aureus compared to clindamycin. It would be a better or a more superior choice. Now, changing from cefepime to meropenem will not improve staphylococcal cover. Remember, meropenem does not cover MRSA. The best choice in this case would be to add vancomycin and await culture and susceptibility reports. Let's move to the next question, please. And it reads, Master TJJ, a 13-day-old boy who was born 2 weeks premature is brought to your pediatric A&E by the mother. He currently feeds on formula milk, and the pediatrician examines him and is concerned about bacterial meningitis. He has no known drug or food allergies, so my question to you is, which of the regimens listed below would be the most appropriate for Master TTJ's treatment now? Would you settle for ceftriaxone and vancomycin? Would you settle for ceftriaxone and gentamicin? Or would you treat him with ampicillin and gentamicin? Or would you settle for ampicillin and vancomycin? I'll give you 10 seconds to choose the correct answer. I would treat TTJ with ampicillin and gentamicin. Remember, the IDSA bacterial meningitis guidelines state that ampicillin plus cefotaxime or ampicillin plus an aminoglycoside are the empiric treatments of choice for bacterial meningitis in a patient who is below the age of 1 month. I'd like to emphasize that ampicillin is needed as part of the empiric regimen due to its effectiveness against Listeria monocytogenes, which is a common pathogen in patients below the age of 1 month. I'd just like to add that ceftriaxone, which appears in alternatives A and B, is contraindicated in patients up to a post-menstrual age of 41 weeks, that is gestational age plus chronological age, due to the risks of hyperbilirubinemia, since it displaces bilirubin from albumin binding sites. Remember that. And this could increase the risk of what we call kernicterus. It's a neurological condition in these neonates. Now, MDRS streptococcus pneumonia is rare in patients below the age of 1 month, and it precludes the routine use of vancomycin. I would just like to add that, and to repeat myself, that ceftriaxone is contraindicated in neonates below the age of 28 days. And if they require or are expected to require treatment with calcium-containing IV solutions, then it's also indicated because of the possibility of precipitation of the ceftriaxone. And that precipitation can also occur if such patients receive parenteral nutrition which contains calcium, because of that obvious reason that there is precipitation of ceftriaxone. So avoid its use below the age of 28 days or when IV calcium containing solutions are used. Let's move to the next slide, please. And there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel and to leave your comments at the bottom of this video. I would like to promise you all that the very, very best is yet to come, and I thank you all sincerely for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you in subsequent videos. Thank you.